Hello again, dear students. Today we are talking about the oral mucosa and its structure. This is a rather extensive chapter because the oral mucosa itself has a rather complex microstructure, and then there are so many different regions in the oral cavity in which the oral mucosa has a correspondingly different composition. And then there is also the gingiva, which also has a quite complex internal structure. Well, you have to know all this. The oral mucosa. What do we expect in this lecture? First, we will get an overview of the different regions of the oral cavity. There are clear differences in terms of its thickness and structure. We will then have a closer look at it in detail. And therein also lies the potential to regenerate itself. And of course, as always, we also want to know how the oral mucosa is formed in the first place. And we do not leave the clinical correlations unmentioned. To begin with, as always, I will give you some literature references here. You will of course find everything I talk about in this lecture in my textbook, Oral Structure and Developmental Biology. The page numbers are on the corresponding slides as always in the upper left corner. And the same applies to our atlas, the face. And furthermore, there is also special literature on this topic, even a whole textbook just about the tongue by Andreas Filippi. And there are also other good textbooks like the one about oral anatomy by Bero Berkowitz or oral cells and tissues by Phileas Garand. Let us start with the topography. Have you ever taken a thorough look at your oral cavity yourself in the mirror? You will notice that it is colored with different shades of red. Actually, the oral mucosa is quite transparent, and what shines through in red, that's the blood. And depending on how thick the mucosa is, it appears with these different shades of red. On the palate, we see a large extended region where the mucosa is rather pale pink. Here it is quite thick, and therefore the red color of the blood vessels does not really come through. But further in the back, at the soft palate, where it is mobile, there the mucosa is comparatively thinner, and therefore already more of the blood vessels can be seen. So it appears dark red here. And you can even follow the course of some individual thin blood vessels. And the pharynx in the picture on the right is also lined with a deep red mucosa, and also here it is rather thin. And yes, it is true. The palate and the cheek bear a cornified mucosa. Of course, not as thickly covered with horny skin as the soles of your feet, but still there is a certain layer of horny skin on it. And these regions on the cheek and palate, and also the light pink portions of the gums, are called the masticatory mucosa. And the other deep red areas which are thinner, they bear a lining mucosa, which is how it is referred to here. And examples include the areas under the tongue or the floor of the mouth. And there are special areas like the tongue, which carries special lingual papilla on its back and laterally, with the naked eye visible, leaf-like papilla. We will discuss the details of this later. An overview of the prenatal development is quickly described. The oral cavity is lined with epithelium from the very beginning, even at the time when there was still a single oral nasal cavity. And in the 12th week, the incisive papilla and the palatine ruga become visible. The epithelium of the gingiva also is different from the mucosa of the lips and the cheeks. In the period between the 12th and the 20th week, the epithelium of the hard palate and the gingiva shows increasing keratinization, which means it has a parakeratinized stratum corneum. And the mucogingival borderline between the gingiva and the oral mucosa becomes visible, and the layering of the mucosa in general from now on already corresponds to that of its afterbirth. In the histological section on the left, the structural layering is clearly visible from top to bottom. Towards the oral cavity, which is located at the upper edge of the image, the squamous epithelium can be seen. It is divided into 4 layers in this section. The stratum corneum is the superficial one, followed by the stratum granulosum, which is then followed by the stratum spinosum, and the lowest layer of the epithelium is the basal stratum. We will discuss what's the meaning of these anatomical technical terms in a few minutes. And the border with the lamina propria is usually not smooth or straight, but these 2 layers are connected by cone-like more or less distinct papillae. In this entirety, this layer is called the papillary body. And below this lies the lamina propria, and still below that one there is the submucosa. In this layer, depending on where we are in the oral cavity, we find different amounts of fat, glandular tissue, blood vessels, and of course nerves. And not in the picture is the bone, but underneath the entire mucosa there is of course bone, on the palate for example. And in the following, we will go through the typical components of the oral mucosa layer by layer. There are some variations depending on the region in the oral cavity, but the principle is generally the same. Let us start with an epithelium that is called orthokeratinized epithelium. This is an epithelium that has a more or less thin cornified layer on its surface. And the lowest layer is the basal layer, the stratum basale. And this is a layer of cells that are constantly dividing. Yes, if you will, you may address them as stem cells. And these cells, which can constantly divide, these cells are the reservoir for the mucosa, which is constantly renewing itself. And the stem cells can be identified by the fact that they are initially undifferentiated cells, in contrast to the keratinocytes that arise from them. These also lie in the basal stratum, and because they differ from the stem cells in their differentiation, I have also drawn them in a different way with such a wavy contour of their membrane. And these cells, the keratinocytes, they can no longer divide. What they do now is they migrate upward, or they don't even actively migrate upward at all, but you can also think of it that these cells are being pushed upward by all the cells that are constantly coming out of the basal stem cells through ongoing cell division. But there is something happening to them on the way up to the surface to the skin. They are changing their internal structure and their external shape. We will also see, if we follow this further, the typical cell organelles, which you all know. Their number and their distribution changes on the way up. And the cell plasma also becomes less and less on the way up. One of the reasons for this is that from now on these cells are no longer properly nourished. A direct supply with blood vessels is no longer given to this layer. The next layer is the stratum spinosum. Here you can see the number of desmosome connections between the individual cells has increased. Inside the cell, the number of tonofilaments has also increased. So these cells are still able to differentiate in a typical way. The desmosomes and the tonofilaments mean that the cells are more tightly connected to each other. They are more tightly bound together and can no longer simply move against each other anymore. Now, when the cytoplasm becomes less, after all, the cells are no longer nourished, but they constantly produce all these organelles. then you can see under the microscope how the cells form some spiky contours in places where they are tightly attached to each other. And that is why this layer is called the stratum spinosum, because of these spine-like sharp edges. And have you noticed that in the cells of the stratum spinosum, the number and density of the endoplasmatic reticulum has also increased? These are the protein factories that form the tonofilaments. And not only these, but also the keratohyalin granules. And after all, we are in the layer of a keratinizing epithelium. And these keratohyalin granules are typical for the stratum granulosum. They can easily be seen in the histological section, which is why they are called this way. And the cytoplasm has become even less. There are more keratohyalin granules, and membrane lining granules have now been added also. Some of these, and also their contents, are also getting into the intercellular space. I've indicated this schematically in the middle in the diagram between the two cells. The cells are becoming increasingly flat. Even the nucleus shows this increasingly flat shape. And here, in the uppermost cell layer, the density of the keratohyalin granules has increased even further, and the network of tonofilaments and tonofibrils is also more densely interwoven. And these architecture give the skin, including the mucosa here, its fairly good tearing resistance. The cells are really tightly interconnected. And at the very top of the surface, all that remains of the cells are their horny remainders, which is the dead horny fragments. From the former keratocytes in the basal cell layer, in which the stem cells provide constant replacement, these horny flakes have developed on their way to the surface. This is a constant process. The cell division rate is quite high here. And on the skin you can even see this renewal of the cells. You will therefore always find these tickling dandruff on the dark lapel of your blazer or jacket. The whole skin is constantly regenerated everywhere on the skin, where are these skin flakes which constantly peel off. And yes, if you look at it very closely, if the pizza baker kneads the pizza dough by hand, then strictly speaking there can never be any truly vegetarian pizza. So now we have gone through all the typical layers of the orthokeratinizing epithelium of the oral mucosa. This can be seen on the left in the schematic drawing. And in the right picture, I have drawn a parakeratinizing epithelium. The two layers, to the lower layers, are the same, although the second layer, the stratum spinosum, is also called stratum filamentosum by some authors. This refers to the presence of the many tonofilaments, which we have discussed already. And however, in this parakeratinizing epithelium, the stratum corneum is not quite as strongly developed, and therefore two uppermost layers are grouped together as the stratum distendum. In principle, they are sort of similar, but there is less cornification. And this occurs in the oral cavity in the different regions. After this overview, we can take another closer look at the basal cell layer. On the left, we see a histological section from the floor of the mouth. And here, the epithelium shows very little keratinization, so it is only three-layered. A thick keratinized layer on the surface does not exist here. In the basal cell layer, we can see the stem cells, labeled B, in the schematic drawing on the right. And above, at C, the differentiated keratocyte, of which so many migrate to the epithelial surface or are being pushed up there. There are still some special cells in the epithelium. Normally, the color of the oral mucosa appears to be a pale pink, but it is actually transparent, but the blood shimmers through a little bit. But we also find melanocytes in the basal lamina. Here in the picture, marked with M. They supply the keratocytes with melanin granules, and these melanocytes are present in about equal numbers in all people, There are about 7 to 9 melanocytes per 100 basal cells. In more pigmented individuals, the melanocytes then produce more melanin and more melanosomes are deposited in the plasma of the basal cells. And the gingiva can then also look brown in these individuals. And between all the keratocytes, there are some other cells, like some isolated Langerhans cells, here in the picture marked with L. These cells are interesting. They come from the bone marrow. They have left the bloodstream and enter the epithelium via the lamina propria. And what are they doing here? So these cells are part of the cellular immune system, which of course is very practical in the oral mucosa, isn't it? There are even more different cells to be found here in the epithelium, like for example lymphocytes and Merkel cells. And the details are very complicated, and I recommend that you read up on them in your textbook. What I had mentioned earlier in the first overview, here we can look at it again in more detail. The so-called papillary body, which establishes the connection between the epithelium and the lamina propria. On the left at A, we see a histological section from the textbook of Antonio Nancy, very clearly pronounced pegs the arrow points to an extension of the lamina propria that protrudes far into the epithelium. And in the middle image, we are looking at the lamina propria from the top. The epithelium has been removed. And in the image C, we are looking at the underside of the epithelium. There we can see the many cones that have penetrated the lamina propria. They can be very variable, different in length or very short and wide, many or few. And this affects the strength of the connection of the epithelium to its support. And this varies in the mouth in different regions, which we will discuss in more detail in a moment. Having looked at the general structure on the oral mucosa up to this point, we can now look at the specific regions in the oral cavity. Let us first take the lip. The mucosa of the lip, that is, the area opposite the teeth, here the epithelium is about 0.5 millimeter thick, not keratinized. It has rather short papillae, and therefore the mucosa here is also easily movable or displaceable on the submucosa, which is dense and firm. And this type of oral mucosa can be called a lining mucosa. And the red of the lip, that is what most people call the lip, has only a very thin, well transparent epithelial coating, and the blood vessels show through very well, otherwise the lip would not be so red here. However, the epithelium in here is keratinized, and the papillae to the submucosa are long, and the submucosa is dense and firm. The lip red is called a specialized epithelium. Well, it only occurs on the lip in its red area. In the histological section here, cut vertically through the lower lip, shows even more interesting details. Where it says facial on the right, there is the facial skin, labeled F, and you can also see the shaft of a hair in the section plane here at H. And opposite, where it says oral, there is of course the section of the oral mucosa, and the red of the lip is marked with R. Here the blood vessels lie very close under the surface, and the larger blood vessels are exemplarily marked with B. And in the center with M, the cross-section of the orbicularis oris muscle is marked. And with SG, one of the many salivary glands is seen in the section. And remember, there are not only these 3 large paired salivary glands, but one can find many small individual salivary glands pretty much everywhere in the oral mucosa, as here in the section. The magnification shows the red of the lips. It is very thin, transparent, has no skin appendages, only a few sebaceous glands, and in the area of the corners of the mouth there may be a few more. And here is another magnification showing an area of oral mucosa at the lower lip in more detail. Here, as mentioned, the epithelium is about 0.5 millimeter thick, not keratinized, has short, irregular papilla over a fairly broad lamina propria. And here you see them in higher magnification, many individual salivary glands, SG. And in addition, numerous connective tissue strands are running from the mucosa to the muscles. You should not be scared of this tongue here in the left picture. I hope your own tongue does not look like that when you look at it in the mirror. What's that stuff on here? Well, the back of the tongue is not completely smooth, but there are many different typical papillae. One type of these are those with fine horn filaments called filiform papilla. If you are licked by a cat, maybe you could not avoid that. You will notice that the tongue of the cat can be quite rough. Cats do have a particularly rough tongue with well-developed horny papilla. And a lot of grime can get trapped in these horn threads, which is a pulpy mass of exfoliated epithelial cells, debris, and food leftovers that is nicely metabolized by the bacteria. And in case you have bad breath, this could be a possible cause. However, your tongue does not have to look like this. It must not even look like this. You can go to the dentist, regular checkup and cleaning, and you will learn that you should not only brush your teeth, but also clean your tongue. There are these special tongue scrapers, but you can also clean your tongue with the toothbrush very easily. With a little bit of courage, you can also do it further back, that is, up to the palate papilla. And then your tongue will look rather as clean and pleasant as the one on the right in the picture. And here you can also see many small vertical serrations on the side. These are the foliate papilla. We will talk about them in more detail in a minute. And briefly on histology, the epithelium is thick and keratinized. Think of the horn papilla. And the papilla between the epithelium and the lamina propria. Now, these are the papilla that are not on the back of the tongue, but here we think of the pegs between the tissue layers that I just mentioned. So these papilla, they are long. And the lamina propria is quite tightly connected to the underlying muscles. Yes, this is obvious. The tongue is really well mobile, and you can feel for yourself that its epithelial covering sits tightly on it. And this type of oral mucosa on the tongue is considered as a specialized epithelium and is called gustatory because of the many taste buds. And this is now just applied to the front 2/3 of the tongue. And the posterior third of the tongue, further back here, no longer completely in the picture. Here the epithelium is generally not keratinized. The papilla, those pegs between the tissue layers, are short or absent, but the lamina propria is well connected to the tongue musculature, just as one of the rest of the tongue. And now it's time to familiarize ourselves with the topography of the tongue, which I have summarized in this diagram. We look at the back of the tongue, and we start at the bottom on the picture and the tip of the tongue. It is labeled apex linguae. And from here, the sulcus medianus linguae pulls back in the middle. Some people can contract their muscles of the tongue so that there is actually a groove that forms in the middle. And on the body of the tongue, the corpus linguae, there lie these many filiform and fungiform papilla, which we will look at in more detail in a moment. Laterally, the foliate papilla are present, and obliquely to the center of the tongue are about 5 large round papilla per side, the palate papilla. Behind this, there is again a sulcus, and this time the sulcus terminalis. And in the middle, there is a spot about the size of a lentil, sometimes about the shape of a diamond, often leaving a dent or an indentation ending blindly. This is the foramen caecum. This is where the site where the formation of the thyroid gland began to form at the epithelium at the embryonic time. In the course of development, it has migrated towards the neck and no longer has an excretory duct because it has become an endocrine gland. For orientation, I have also drawn the edges of the palatoglossal arches at the margins and those of the palatopharyngeal arches at the back. And at the back in the center, at the top of the picture, you can see the laryngeal cover, the epiglottis, and the root of the tongue, the radix linguae. And at the base of the tongue, which is the area between the palatoglossal and the palatopharyngeal arches, there are the many individual entrances of the tongue tonsil. And in addition, on the left and on the right behind the palatoglossal arch, there are the big tonsils, everybody knows, the palatine tonsils. And if you then add the pharyngeal tonsil, which is not included in the diagram, then you have described the lymphatic pharyngeal ring named after the anatomist Anton Waldeyer. Now we come to the muscles of the tongue. The upper image shows a schematic drawing in a sagittal section with the teeth on the right, and the one below is a transverse section. Under the mucous membrane of the tongue, a coarse aponeurosis linguae stretches out over the dorsum of the tongue. This is where the muscles of the tongue are attached. There is a longitudinalis muscle running lengthwise on both sides of the middle, and below it there are transverse and short vertically running muscles. And the largest portion is occupied by the genioglossus muscle, which originates from the lingual side of the symphysis of the chin and from the hyoid bone, and then radiates into the tongue in a fan-shaped manner. Below the transversus linguae muscle, there is another inferior longitudinal muscle running again lengthwise on both sides. And there are some other muscles which we do not directly address as tongue muscles. They are the geniohyoid muscle, which runs in pairs from the symphysis to the hyoid bone, and the mylohyoid, whose fibers extend transversely from the inner side of the mandible as a flat muscle, creating the floor of the mouth, albeit drooping like a hammock. Here in the histological section, this is clearly visible, especially on the right, how the muscles run criss and cross and transversely in the body of the tongue. With these many muscles running crosswise and lengthwise in the tongue, it is, as we all know, very mobile and delicately controllable. So and now, here is another schematic picture. On the back of the tongue I have symbolized the filiform papilla on the left as upright triangles, and in between there are many fungiform papillae. And these fungiform papillae have a diameter of about half or 1 millimeter, and you can see them well with the naked eye. And if a patient has scarlet fever, then these are particularly prominent, and then this condition is called a strawberry tongue. We had already discussed the other structures in the diagram earlier, but on the right side I have again drawn in color the different zones of taste perception. But these zones are rather theoretical, a separation that is, well, academic. There are enough taste buds on the tongue that can perceive all tastes, so you don't have to take the scheme too strictly. Now let us take another look at the papilla on the tongue, now more in detail. This beautiful specimen is a sagittal section through a filiform papilla of the cat. It has particularly pronounced horny filaments labeled H. In humans, it is much more delicate and softer. And several secondary papilla originate from the primary papilla. And the secondary papilla still have many blood vessels running through them. And this horny needle, which covers the entire papilla, is ultimately a continuation of the oral epithelium, which of course is not as much keratinized. The lamina propria can be further subdivided into a papillary and a reticular layer, and at the bottom of the picture the strongly structured tongue muscles can be seen. The fungiform papilla are already macroscopically visible as round, bright red dots on the tongue. They are less numerous than the horn papilla, which we have just discussed before, and they are scattered between them. On 1 square centimeter we find between 50 and 100 of such papilla, depending on the region of the tongue. And these papilla are up to 1 millimeter long and are surrounded by a thin wall. In the left picture, this is a scanning electron micrograph, by the way, of my own tongue. So you see here a papilla of mine personally. And again, there are small secondary papilla on the primary papilla with taste buds on the tip. And if there are several different taste buds on one papilla, then the papilla can also register different taste sensations. These are sweet, sour, salty, and bitter. And there are even further qualities like also water, fat, and umami, which means meaty. These papilla appear comparatively well-colored red in the tongue. And this is due to the many tiny arteries and veins that form a vascular plexus in the papilla. And here's another histological section that I was able to contribute to the tongue chapter in the textbook on the tongue by Andreas Filippi. Here you can see very nicely how several fungiform papilla protrude from the oral epithelium. At this point, we can briefly take a closer look at the structure of taste buds. They are found in every taste bud of the tongue. They are quite small, so only 30 to 80 micrometers in diameter and 50 to 80 micrometers in height. If they are made up of about 30 to 100 individual cells, they are very small. Like the epithelium in general, the cell population of the taste bud is subject to continuous renewal, so about every 14 days all cells are always renewed. This can be also remembered easily, isn't it? If you have burned your tongue, you will have forgotten it after 2 weeks at the latest. And by the way, taste bud cells are dependent on being innervated. If they are not innervated, they are prone to atrophy. And when the nerve fibers are regenerated and have grown into the epithelium of the papilla, then new taste buds arise from the cells of the papilla epithelium. In this diagram, you can see different types of cells in the taste bud. I have drawn them with different shades of gray, so we distinguish type 1, 2, and 3. They are indeed different in brightness, and there are even more differences described in detail in the book. In this lecture, I will not go into further details now. Now here, it becomes again somewhat more descriptive, that is, less schematic. Here are the foliate papilla. This means the leaf-like papilla. They are located vertically on the left and right sides of the tongue. There are 8 and 15 such vertical arrangements per side. And in the vertical slits, that is where the taste buds are located, as can be seen well in the histological sections. People say when tasting wine you should swirl the wine around back in the mouth, here around the tongue, in order to be able to perceive all of the fine nuances of taste properly. So just swallowing it quickly, that doesn't do justice to wine as a precious culinary drink. But it's not just about taste alone, it's smell also that's released from the wine in the mouth also plays a major role. And with a diameter of 2 and 3 millimeters, the wall papilla are the largest papilla on the tongue. There are only about 8 to 10 of these, and you can see them pretty well if you stick your tongue out widely. In fact, they are surrounded by a circular crevice in which the taste buds are sitting again, and there are many small salivary glands underneath, which are called von Ebner's irrigation glands. And next to the circular slit, it results that you see a wall on the surface of the tongue, and that is why they are now called the papilla, with walls, the wall papilla. The last thing we now need to look at with the tongue is the mucosa on its underside. And here the epithelium is quite thin, 3 layers, and there is no stratum corneum here. Papilla, well, those like on the surface of the tongue, but here we are talking about the papilla between the epithelium and the submucosa. So these papilla are hardly present here, and there is also a lack of submucosa. Instead, the lamina propria is loosely connected directly to the fascia of the muscles via connective tissue fibers. And the epithelium is also very thin at the base of the mouth. The lamina propria is also very thin, and here there is also very few papilla between the epithelium and the lamina propria. Within the submucosa, there are fat cells and many individual seromucous and rather mucous salivary glands, collectively referred to as the sublingual gland. The oral floor mucosa here is only loosely connected to the mylohyoid muscle. Because it is also thin here, you can see the blood vessels very well. Completely different is the buccal mucosa. It has a rather thick epithelium through which you cannot see any blood vessels. The epithelium is described as extensively non-keratinized. However, locally there are clearly recognizable zones of keratinization. Usually at the level of the masticatory plane, or the occlusal plane, there is such a white line, the linea alba, running along. And in boys after puberty and in women after their menopause, individual sebaceous glands can also be found on the buccal mucosa. The lamina propria is dense, thin and firmly attached to the muscles. And the buccal mucosa has no mobility of its own, so it cannot be lifted from the base, but it goes along with all the movements of the muscles. Now we come to the palate. Here we must first differentiate macroscopically between the hard palate and the soft palate. The soft palate is the area that is freely movable at the back, and it has no bony base. In the hard palate, on the other hand, the lamina propria is very thin and close to the bone of the maxilla, and the papillae are long, and the epithelium is thick and keratinized with all four proper layers of a keratinized squamous epithelium. And here we can histologically demonstrate 10 to 12 layers of horny scales. The diagram on the right shows the situation as it is found along the white line transversely in the middle of the palate, approximately at the level of the first molars. There you can see the thick epithelium, the lamina propria, and parts of the bone. And if you follow the extension of the hard palate in the frontal section, it can be seen that the epithelium lies so close to the bone in the middle, in the fibrous median zone, and at the edge in the fibrous marginal zone, that no submucosa is present here. And only in the areas in between is there a submucosa under the epithelium, and here fat cells and many isolated salivary glands can be found in the epithelium. And of course you see the major palatine artery far right in the image of the palate. And the soft palate shows the peculiarity that it not only has a mucosa on its oral side, but it also is covered with mucosa towards the nasal cavity. Here it bears a ciliated epithelium, which is a typical respiratory epithelium. The epithelium towards the oral cavity is just as thick as on the hard palate, but is not keratinized. And here at the transition we also find taste buds embedded in 10 to 30 islands of keratinized epithelium. And in the soft palate there are also many salivary glands in the submucosa, which is strongly vascularized by the capillary plexus of the minor palatine arteries. And the soft palate is mobile because there are also muscles to move and tighten the tissue here. The tensor veli and the levator veli palatini muscles run through it, not shown here though. And there is an elastic connective tissue plate inside that provides some stability. We have now looked at almost all the different areas of the oral mucosa, but not all of them yet. The gingiva is still missing. We will deal with this in more detail in a moment. Here in the left image I have drawn a white vertical line distal to the lower right canine. It shows the transition from the gingiva to the alveolar mucosa. The gingiva is firm, so that is why it is called attached gingiva. The epithelium is thick and keratinized, at least parakeratinized. And the epithelium here is firmly engaged to the lamina propria with long, narrow papilla, and there is no submucosa. And the alveolar mucosa is quite different. It is non-keratinized, very mobile, and beneath the thin lamina propria lies a very well vascularized submucosa. The morphological boundary between the mobile alveolar mucosa and the gingiva is easily recognizable based on its coloration alone. The gingiva is pale pink and the alveolar mucosa is dark red. Here the many blood vessels can be seen shining through. And the gingiva occupies a special position in the oral mucosa because it also represents the part of the tooth-supporting tissue which lies mostly peripherally. The gingiva surrounds the teeth as a free and as an attached gingiva, and then merges into the alveolar mucosa. The border is also very particularly well recognizable here in the image by the different intensities of red and coloration of the tissue. And now we need to take a closer look at the structural features of the gingiva. It is amazing to see the variety of tissue details found here, most of which are really important for anchoring the teeth healthily in the oral cavity. You know, in dentistry there is a special field called periodontology, and in many countries there is even a residency necessary in this field. The subtleties of the anatomy alone are rich in detail. So let us start in the picture A below. The tooth, of which you cannot see much here, except for a small margin on the left side of the diagram, is connected to the alveolar process bone by many individual fibers. They pull from the thin cementum layer, labeled C, covering the root, directly into the bone. Another periodontal supporting fibers extend from the cementum in a fan-shaped spread into the attached gingiva, anchoring it firmly to the neck of the tooth from the inside. The uppermost part of the gingival collar around the tooth consists of the so-called free gingiva. Sometimes a gingival furrow can be seen as a border. And for orientation, the outer part of the free gingiva is called gingival sulcus epithelium, and the area facing the tooth is called oral sulcus epithelium. Now, this is not a mistake. I have read it up everywhere. The part facing the tooth is called the oral sulcus epithelium. I really don't think that makes much sense here. This area faces the enamel and has not so much to do with the mouth. But for these names, it's not my fault. So in contrast to the highest point of the gingiva, which is the transition from the gingival sulcus epithelium to the oral sulcus epithelium, it is called the gingival margin. And yes, that's easier to remember, isn't it? And now let us look at the marginal epithelium. In the image labeled with the letter A, I have drawn a box to indicate the localization of the section B. The marginal epithelium is not visible from the outside. It borders the gingival sulcus epithelium in the depth of the gingival sulcus and surrounds the neck of the tooth like a collar. It is interesting to note where the cells of the marginal epithelium come from. They are, at least when the tooth newly erupts into the oral cavity, from former ameloblasts. In a tooth that is about to erupt into the oral cavity, the crown is still covered by an epithelium consisting of the ameloblast and the stratum intermedium. For further details, I must refer to the chapter on tooth development. But it is really interesting to see for which different further tasks the ameloblasts, which already had to do so much during enamel formation, are then additionally used. There is also a distinction between a primary and a secondary epithelial attachment, but for these details I have to refer you to the textbook again. Too many details would make this lecture too boring. And now, a few more details about the junctional epithelium. The overview at A shows that we want to take a closer look at the region of the junctional epithelium. Let us start in image B. E, of course, refers to enamel. In all the textbooks, the dental cuticle was still referred to as the secondary enamel epithelium, or also as the cementum epithelium. However, it is newly formed before tooth eruption, and therefore it is not just any leftover of the enamel epithelium. But only after tooth eruption, when the junctional epithelium comes into contact with the enamel. It probably arises as the product of inflammatory reactions in which the serum proteins are deposited at the border between the tooth and the epithelium. The junctional epithelium has the peculiarity that it has two basal lamina. Here now, first of all, the internal basal lamina. It consists of a lamina lucida and a lamina densa, which is quite common. The junctional epithelium cells attach themselves to the lamina lucida with half desmosomes, and the lamina densa lies on the surface of the teeth. Adhesive and cohesive forces act between the individual layers, which overall ensure adhesion of the marginal epithelial cells to the tooth surface. And thus, a cuff is mechanically placed around the tooth, which is, of course, an important part of the sealing and infection defense of the underlying periodontal tissue. JE refers to the cells of the junctional epithelium. And here, this is the external basal lamina. And now, this is a normal basal lamina, as it is found in every other epithelium. I have drawn here a little darker pink, the stratum basale of the epithelium that lies on top of this basal lamina. This is followed by the lamina propria, which contains the blood vessels and among other components. And in the image C, the cells of the junctional epithelium can then be seen again, but we are now further down to the depth of the epithelial attachment. We already know the inner basal lamina and also the dental cuticle. It can be seen here, however, that it does not always extend down to the depth of the entire enamel, to the enamel-cementum junction, because there are also cases where some portions of the enamel are covered with acellular afibrillar cementum, referred to as AAC. And on the opposite side, the usual external basal lamina can be seen again. And in this image section C, you can also see a little more of the enamel labeled as E. And below that lies the dentine. And before we come to image D, a brief explanation of the structures at the bottom of the image. On top of the dentine lies the acellular extrinsic fiber cementum, AEC. And from there, collagen fibers, CF, extend into the lamina propria. In section D, we are again on the other side in the overview image at A. So now the dentine is again on the left edge of the image and the enamel to the right of it above. And here I have shown the situation in such a way that the junctional epithelium does not lie directly on the naked enamel, but the enamel is covered by a layer of acellular afibrillar cementum, referred to as AAC, which is somewhat larger than in image C. This is quite common. And then the internal basal lamina does not lie directly on the enamel, but on the layer of cementum. And then the internal basal lamina does not lie directly on the enamel, but on the layer of cementum. There are no changes for the junctional epithelial cells, and also no changes for the basal lamina. And before we leave this image, a brief explanation of the structures at the bottom again. LP, this is of course the lamina propria, in which blood vessels, BV, can be seen. And in the direction of the root, the fibroblast, FB, can then be seen in the connective tissue which produce the collagen fibers, CF, that bond with the acellular extrinsic fiber cementum, AEC. Now we will take a look at how the supporting fibers run in the gingiva. In diagram A, they are all depicted, and we will discuss them in detail in a moment. And picture B shows the overview in view from the front, so we know where we are in the scheme to the left. There you see just a little bit of a contour of the tooth. E stands for enamel and D is dentine, and at the top there is the gingival sulcus, the oral sulcus epithelium, and the gingival margin, all marked GS, OS and GM, so much for orientation first. Now, there are the coronal fibers, the coronal gingival fibers. These fibers run from the cementum close to the enamel cementum junction across the alveolar crest and coronally into the gingiva. In here they extend to just below the epithelium and hold the gingiva to the crown firmly and tight, if it is healthy. Any inflammation would also lead to loosening of the fibers due to the bacterial enzymes, and in this way they would weaken or even render ineffective this beautiful, also mechanically effective protection against infection. And directly below, the horizontal fibers, the horizontal gingival fibers, extend from the cementum predominantly in a horizontal direction across the alveolar crest. And again, below that, which is really well ordered, at least in this schematic drawing, there are further fibers, which are called apical dentogingival fibers. They also originate from the cementum and run over the alveolar crest, now obliquely downward to the gingiva. Of course, they do not reach the root of the tooth. Apical, in their name, refers only to the rough downward direction. And in this scheme, number 2 refers to the dentoperiosteal fibers. They run from the cementum of the tooth across the alveolar crest and attach to the outside of the alveolar bone into its periosteum. Then there is another group of supporting fibers which no longer originate at the tooth, but at the alveolar crest of the bone and extend up to the gingiva. And they are then called alveolo-gingival fibers. And numbers 4 and 8 identify fibers that run all around the tooth. So I could only draw them sort of sectioned here, so you can only see points that are supposed to represent these fibers. Some of them run completely around the tooth, some others make it only half around. That is why they are called circular and semicircular fibers. And then there are some other fibers that leave the circle around their own tooth and move to the fiber circle of the neighboring tooth. And these are then the intercircular fibers. And directly below there's another fibrous circuit, but these fibers do no longer run around the tooth, but they run in the gingiva as transgingival fibers and intergingival fibers. Well, and then there are fibers that run from the bone to the gingiva, and they are called the periosteal gingival fibers. Number 7. And however, if you are strict about nomenclature, they do not actually run to the gingiva, but into the alveolar mucosa, because we are already below the mucogingival boundary. Isn't it so? That was quite detailed up to now, and that's not all. Here is another drawing that represents the gingival fibers now sectioned transversely. So here you can now see how the fibers run between the teeth, which means within the interdental papilla. In image A, we are looking exactly into the area between two neighboring teeth. The teeth can just be seen cropped at the edges of the image. So E stands again for enamel and D again for dentine. And in the image on the right, image B, we are again looking into the interdental papilla, but this time cut transversely in such a way that we can follow the course of the fibers from buccal to lingual. There is no number 1 here in this scheme, and these were the dentogingival fibers in the scheme from before. I could not show them here because I want to keep the numbering, and so at the 2, these are the dentoperiosteal fibers. They pull from the cementum obliquely into the alveolar crest. And for number 3, which applies to both diagrams, the alveolo-gingival fibers run vertically from the alveolar bone to the gingiva. And number 4 again refers to the fibers, which I could only show as single points in the diagram on the left. These are the circular and semicircular fibers, so they run around the tooth in a circle or in a half circle. And you can see this better in the picture on the right. And similarly, the 5, which are the transgingival and intergingival fibers. And you see everything is well connected to each other. And then there are the interpapillary fibers, which ensure that the vestibular and the lingual portions of the interdental papilla are well held together. The posterior gingival fibers run from the alveolar bone to the parts of the gingiva covering the bone, but strictly speaking, as also mentioned earlier, we are no longer in the gingiva here, but already in the alveolar mucosa. At number 8, the intercircular fibers are cut here again. They connect with the circular fibers bundles of the neighboring teeth. And number 9, these are the transseptal fiber bundles. They run in the interdental gingiva and connect the supraalveolar portions of the root cementum of adjacent teeth across the interdental bone septum. And thus, all teeth are connected to each other. Collectively, these fibers are also referred to as the interdental ligament. So if you want to remember all of this in such a detail, it is quite complex. All these special fibers and fiber directions and the many names for them, which of course describe exactly the course of the fibers. One may also say it in much easier words. All possible structures are connected with each other here, so every anatomically comprehensible part has somehow a fiber connection to another anatomical structure in that area. I can also imagine that this jumble of fibers, with all the different crisscrossing courses, was somehow already present in the edentulous gingiva before any tooth did erupt. And then, when a tooth erupts into the oral cavity, then the fibers arrange themselves structurally under the functional tension between tooth and gingiva, as we have just described. Of course, there are also the many other fiber tracts that attach to the cementum of the root. I wanted to make it a little easier for you with this thought. So that was really quite a complex and detailed chapter here now. And here is the summary, and I could read this whole table to you again as a take-home message. But I will spare that to you. You can just now press the pause button or read about it on page 356 in the book. The table is also in there. And with this picture of my horse Poseidon, I thank you for your kind attention.